afternoon. I want to give just a couple more minutes. I know we had a lot of interest, and there might be people who are rushing to get onto their computer, so we'll give them just a couple more minutes, but we will start at the top of the hour. Well, my computer tells me it's straight up noon, so we'll go ahead and get started. And I want to also thank those of you who do have your cameras on. I don't always like to join meetings also with my camera on, but today, because I'm introducing our guest speaker, I wanted to do that, but I'll probably shut mine off too in a little bit. Kathy from our office has put some housekeeping details in the chat box. We're recording today's webinar, so if you want to go back and listen to it or see material again, or somebody else in your office wants to, it will be archived on our website, and so it's always going to be available to you. She'll also mute your lines so that you don't have to worry about the phone ringing in your office, those sorts of things. We hope to have time at the end of today's session for you to ask questions, and the easiest way to do that would be to put them through the chat box. It tends to help keep things a little bit more organized and recorded. And let's see. I also wanted to let you know that there will be an evaluation that we'll send out afterwards. We do appreciate your input on that. And before I turn this over to Diane, just a couple of more things. This is the first in a series of 4 webinars that Diane is going to be doing for us. And so the next one coming up on November 1st is hypertension. And then she's going to talk on nutrition and exercise on November 29th. And then just after Christmas, she's going to finish up this series with some diabetic resources that are available to you. And we all can use, access and knowledge and where to find resources for ourselves and for our clients. So that'll be an important one also. If you tuned in for Diane's very first session with us, she did it on an update on diabetes medications for diabetes and hypertension. You already know that she's a registered nurse, and she's been a nurse for a long time. And she'll tell you herself that, it's longer than some of us have been alive, but not me. She has a master's degree in business and program planning, and she's also a certified diabetes and health education counselor. So it makes her very well qualified to present this information to us this morning. I don't want to take any more time because I know she has a lot of material to go through, and I want you to have a chance to ask questions. So Diane, if you're ready to go ahead and get started, you want to bring up your slide deck?
Kathy, thank you. I have been an educator for many, many years, and I actually retired from clinic a year ago, but I'm still teaching. So I have great appreciation for that. I have a little housework to do. For those of you who would like continuing education credits, You can email Kathy. Please be sure to give us your discipline because I have to log those in on the correct paperwork, and then I can get your certificates back to you because I have to do that direct. I perhaps may or may not teach the nutrition portion because I do have a dietitian partner. So Maureen and I will figure out who's really going to do the nutrition portion of this class. We do get continuing education credits, from our national resources. So they are good for dietitians and nursing and our mid-levels and or our physicians through the Board of Pharmacy. So today we're going to talk about diabetes basics. It is an overview and review of the new guidelines. It will be very, very interesting come November because the American Diabetes Association and the Board of Endocrinology are looking at doing some updates. So we're all going to sit very patiently and figure out what they're going to change this year very soon in November. We do have a grant from the Department of Health through the CDC, and that makes these classes possible for no fee, which has been an exciting opportunity for us to be able to do. We are going to talk about the newest and the latest things that have come up through all of the work that our national groups have done for us. So we're going to talk about diabetes and hypertension, not hypertension as much today, but mostly focus on diabetes. We're going to talk about the new classifications and how it's going to impact our practice over the next few years. And it is a change in focus, so I want to challenge folks to look outside the box because as we move through these programs, there's more of an emphasis on lifestyle, and we will talk about that. All of us will agree that it's a balance, and that balance and shift is changing as we move into 2018 as prevention, while now that education and those components are becoming, it would be nice to do that, and all of us are actually going to school to become certified in prevention. We're sure that in the very near future, it will be a mandate. So we're moving ahead to look at that. Nutrition and activity, of course, play a huge portion in that balance as we move forward. We can't underestimate the stress, not only those of us who are caring for people living with diabetes or prediabetes, but our patients and our families, and now the impact that it has on the communities. And while we did do a medication review, I will probably ask Kathy if we can do it again because there are 3 new medications that will probably change how we practice in time that have now been approved. So the biggest difference has come in that as recently as August, we talked about the 29 million people with diabetes. The new statistics were just released by CDC, and it has now gone to 30.3 million people, which is kind of scary because it's nearly 10% of our population. And of the 23 million people that are diagnosed, it is more distressing about the folks that are walking out there that are undiagnosed and the impact that they have in our communities. Because we are able now to do clinical evidence-based testing that is predictable, the pre-diabetes facts are a little scary, that there are predicted that there are 84.1 million adults over 18 living with prediabetes. That's a third of the population. So as we look at our group and our communities, that could be as many, I live in Cody, so in the basin there's 35,000 people. That means that 10,000 of those people could be walking around with prediabetes. That's really very scary. And for those of us who are well over 65, and I will admit that, that's about 50% of the population with prediabetes. And I know that I've been part of the clinical trials that have looked at what we can do for prediabetes and are beginning to see those changes. And so as we move forward to 2018, where we can actually bill for it and we can teach for it and we can become certified in that area, I think we're going to see much more work in what we can do to help our folks live longer, live healthier with fewer complications, and perhaps, as we are seeing, folks not not go over the threshold. And we're going to talk about what that threshold looks like in just a moment. I find it alarming that the cost of diabetes is so astronomical. We all know what medicines cost. We know what physician visits cost. We know what the labs cost. I find it equally challenging in the indirect costs. I can share, because I have it in writing, that I have a husband with type 1 diabetes. So when he's sick, I don't work. I take him to the hospital. We miss that time. We know that folks have more complications, therefore they're generally not able to work as long. There are more premature deaths. Even in our neonatal population, we're seeing more complications secondarily to diabetes. So those indirect costs make our communities struggle. And since none of us know what healthcare is really going to look like in the future, since Congress has voted down changing the ACA again, I think this is going to become a more staggering figure. And I think that it's probably some of the reason why the work towards what we can do for prediabetes is going to be so dramatic. So here's Wyoming. We have many, many communities who are doing quite well with their rate of diabetes, but we also have communities that are struggling. They have populations who have higher incidence of diabetes. You can look and see where your particular communities fall. They are also some of the communities who have fewer resources. They may not have a diabetes program where they can refer people to get education. So some of the challenges that we've had in our state is how can we bring leadership to those communities, and we are trying to build maybe not a certified diabetes educator, but someone who is educated, who can help lead their community, whether it's through school nursing or public health nursing or champions in their community. We now have a STEPS program where you don't have to be certified to teach diabetes education. If you go through the STEPS program, you can at least get a level 1 or a level 2 education, so that you know that you're providing evidence-based best practice medicine to your communities. And we can actually come in and support that through the state program that I work with through the health division. And we can give people the resources. We can give you a toolkit that helps you provide, at no cost to our facilities, which is really amazing, evidence-based best practice resource tools that will ensure that our patients and our communities are getting the best information. And in the communities where we have diabetes programs, that we link people up and we link providers up and clinics up so that they know where their resources are, so that folks can enter the healthcare system in a little better format. This statistic is from Joe Grandpré through BRSF data, and this is specifically for Wyoming. And the new data should come shortly, again, probably about November, and this will be updated. But we do have a fairly significant Hispanic population, and of course our Native American population with their diabetes prevalence. So just so that you know. Many, many people have asked us about the age, and finally we were able to provide some data, and again, it should be updated in November when the new guidelines come out. But most of the population of folks that we see with type 2 diabetes, of course, are generally 60 and older. Beginning next year, we should have data for our under 18s again, because they're going to begin to start tracking those again. Most of our folks under 18 are type 1, but we're seeing more and more children with type 2 diabetes. So I challenge our nurses and our folks that are in inpatient or in critical access areas, that just because a child presents with diabetes, do not assume that they have type 1 diabetes. Ask more questions. Are they on oral medications? Some of even our type 2 folks might be on a little basal or background insulin because except for metformin, until they turn 16, there are no oral medications. So if they're not able to control it with diet and exercise and metformin, they may perhaps be on a little bit of basal insulin to keep them under control until they are old enough to be put on more oral medications. And I say that because we have 5 school-age children in Park County that have type 2 diabetes, and it's a mix of how they're treated. So we can't assume anymore, as well as we can't assume that some of our folks over 40 always have type 2. We are seeing more and more latent onset type 1 diabetes in our patients in their 40s and 50s. So that history that we take is critically important now. It's no mystery that as obesity has gone up, that the incidence of diabetes has also gone up. And it may or may not show as well on your slides that you see, but Colorado and Montana and parts of Michigan and Illinois actually have not changed their incidence of diabetes much over 10 or 15 years, and it's because they were part of the original CDC pilots for diabetes education. And 3 years ago, when the pre-diabetes education programs began as pilots, they got the CDC grants to develop those programs. And so they've had active education and intervention, and they are showing that education is making a difference. Colorado has led the group of hardly changing their numbers at all. And when they were asked and interviewed at length, it's because they don't care if it's winter, they don't care if it's summer. They're a very active community. They do have a high socioeconomic group, and most of those people have more than just their basic high school education. So they can afford to be more active, and they choose to eat more healthfully. And now it didn't change when they changed their laws around marijuana. So we always get asked that. But Colorado and Montana especially, Montana actually has stayed pretty even with Colorado over the years, again, because of the educational component. So we are beginning to see the benefits of the work that we are doing. I know that many of you are healthcare providers, but I think it's important for people, again, to look outside the box and remember that diabetes is not one disease. It is a group of diseases with abnormal fasting blood sugars. And impaired glucose has been 100 since 2005. After the ACCORD trial, when the cardiologists proved that the inflammation in vessels begins at more like 150, not 200, those numbers changed. And now that we can reproduce those numbers through C-peptides, which is a very reliable indicator of what's been happening in your body for the last 90 to 120 days, it has stayed that impaired glucose is 100. And it is. How do we digest our food as fuel? How do we convert the glucose into sugar and use that sugar as energy? And what is our pancreas doing? You know, is it producing enough insulin? Is it producing quality insulin, or is it watered down regular gasoline for our bodies? And I think when we remember that a little bit of pathophysiology, which we're going to review again here in just a second, it's a really important function that, that we remember. We look at the 3 main categories of diabetes. Again, as we think about our children with type 1 diabetes and our young adults and not so young adults now, it's that autoimmune destruction of the beta cells that make insulin mandatory. And it can be the viral or bacterial ding to the body that has actually turned off the body's ability to produce insulin. And we see the classic of someone who gets sick, or when you look back and look at the history, the chronic yeast infections, the chronic upper respiratories, whatever it happens to be. Once we do that history, besides the fact that most of them present very, very ill, we can pretty much go back and look in the last 18 to 24 months what started their cascade of their new diabetes, as opposed to the folks with type 2 diabetes who are truly insulin resistant, who develop it generally over time. Most type 2 diabetes has been coming on for 1 to 2 years. And so I tell folks, health fair is your best friend, because you can see the fasting blood sugars in the 80s and then in the 90s. And then as they approach 100, we can begin to look at all those other things. How's their blood pressure? How's their kidney function? And so the second that they cross that threshold and they are now 101, are we going to wait and see if they develop their diabetes until their blood sugars are 126? Or do we want to do something in that period where we actually have more ability to prevent the long-term complications? We all know the moms that develop their gestational diabetes. You know, that's why we screen them so well in that 24 to 28 weeks, or maybe again, if they've kind of been walking the tightrope. That should be our first red flag. The person who has gestational diabetes with 1 or more pregnancies has a 60 to actually 85% more likelihood to go on to develop diabetes later in their life. And then we have those folks that their body is under stress, who have impaired fasting or postprandial glucoses, or perhaps we will induce their diabetes through their huge doses of steroids, their huge doses of medications like methotrexate and Imuran and Humira, things that we might give for other diseases. You need them, the folks who need their prednisone, who need their methotrexate, or perhaps some of our mental health medications like Pristiq and Abilify and Risperidol that all go through the beta pathway, but they will suppress insulin production. And we can actually go on to induce their diabetes. So now we have comorbid states. And the problem with those folks where we induce their diabetes, and the newest group that we're seeing is our cancer patients with their chemotherapy runs, especially our prostate gentlemen who get their huge doses of Solumedrol or Solucortef. Frequently after their second or third run, we can force the beta cells to just quit producing insulin, and they will have horrible blood sugars for that 4 to 7 days after they have their chemotherapy. And that's where the history, that family history, may be important. Many times we will teach these folks, if we know they have family history, or if they all even just have well-managed diabetes, you know, insulin therapy so they can have their sick day coverage so that we keep them out of trouble. But we're seeing a whole new group of people who are inducing their diabetes. So that history has become very critical. And for our mental health patients, it is a huge challenge, because asking them to do anything extra on a day-to-day basis can be a challenge. And that's where the counseling and the education, and frequently a lot more visits, become so critically important. I'm just going to bring this up real quick. Remember that in our pancreas, we have 2 versions of cells. We have beta cells that actually produce the insulin, and we have your alpha cells that talk to your body, that keep that whole glucose piece happening. So in between meals, the liver can let out extra glucose. It's the protective piece that tells you your low blood sugar sensation. And of course, in many cases, with our type 1 folks, over time, they will lose that alpha sensation and they will not have response to their hypoglycemia. Our type 2 folks, when they say, I am so hungry, and people say, oh, it's all in your brain. Well, your satiety center is in your brain. It's your dopamine response. And if your body is not being told that you have eaten, you continue to eat more, which is one of the reasons our folks with type 2 diabetes gain so much weight, and they love eating the calories that truly make them feel well. It's because their gut and the hormones that you have in the gut are not being released in a timely basis to release that dopamine response. So all those GLP-1 and DPP-4 hormones that naturally occur in our gut that should signal the body to produce more insulin, to burn that sugar as energy so that you don't have the huge glycemic excursions, it's missing or it's horribly delayed. We all know that the kidneys love to hold on to glucose. They will reabsorb huge amounts of glucose, which changes your whole kidney profile. It will break down the filters. It will cause people to get more UTIs or yeast infections, and it will make the BUN and creatinine eventually begin to elevate, which is hard on the blood pressure. The new medications that are being developed are an answer to that reabsorption issue. The GI tract, we have those hormones that are very resistant to being turned back on. And while the oral ones that come in the DPP-4s like Januvia and Onglyza and some of those, they have to assume that you have a fairly good beta cell function left. But if you don't, they won't work. And so that's why the injectable versions like Victoza and Byetta and Jardiance, and there's a new one that's out, that's why they were developed, to actually replace the hormones so that your body can begin to do its job. And we all know that once the blood sugars are out of control, greater than 180, 240, certainly the 300 and 400s, then that's when all the damage is happening from the inflammation in the body. And once those inflammation properties take over, we see all the neuropathies that can come and all the cardiac implications that come from the blood sugars being too high. Some of our nursing partners and some of our medical assistants were not aware that insulin is actually a hormone, and it's a natural response, and it's what helps our body to use the sugar stores that are even in your muscles. And that, normally when you eat, as soon as you start eating, as soon as that first bits of food get into your stomach, the body should naturally begin to match the insulin production with the food that you're eating so that things stay at a normal balance. It's normal for your blood sugar to go up 40 to 60 points after you eat. But again, 2 to 3 hours later, everything should be back to normal. And that it's really a two-part process, in that once insulin production has started, also comes along amylin. It's the amount of extra hormonal fuel that you need to keep those blood sugars at that 40 to 60 points after you eat, to prevent the glycemic excursions from being 1, 2, and 300 points, that 2 or 3 hours after you eat. And those are the tools that come to help you to not get gastroparesis, to allow you to digest your food as fuel in a timely manner. So many of our type 1 folks who've had their diabetes a long time will get not only their mealtime insulin, but they will get an amylin product like Similan along with their mealtime insulin so that they don't need so much insulin, so that the body can actually burn its food as fuel. And some of the new medications that are coming are helping to also replace that, because even our type 2s have a diminished version of amylin. Again, the alpha cells are all about keeping you from having low blood sugars. And we actually taught some of the school nurses a few weeks ago how to give glucagon and its glucagon response for our type 1 folks who are unable to keep their homeostasis. I don't need to tell any of you that it's the inflammation that is the worst part of our disease process that is so detrimental to the body. And the longer that you have diabetes, especially type 2 diabetes, the more difficult it becomes for the receptors on our cells to open and do their job and to allow the body to have normal carbohydrate metabolism. And that's when we begin to see other issues. You know, the blood pressures go up, the lipids go up, we see more clotting issues. We see the, people who cannot, no matter what they do, cannot burn their food as fuel, and they continue to gain tremendous amount of weight. And that has all the joint and connective tissue issues that go along with that. Why is it so important? Why has prediabetes become such an issue? Well, if we have the time in that 1 to 2 years as you're developing your diabetes, we have actually seen folks who, with just a minimal amount of care and education, and perhaps early metformin if they can tolerate it, they may have impaired fasting blood sugars, but they will not cross the diabetes threshold. We can actually prevent the insulin resistance from becoming such an issue that in that 5 to 10 year portion that their beta cells will actually die, and then the oral medications are not effective. We can actually look at those folks not developing the severity of complications that give you quality and good quantity of life. And so for some of us who've been part of some of the prevention programs where we've actually changed how we practiced in the last 6 years, we're seeing a different level of outcome. And I think that's been one of the biggest impetus for the whole new diabetes prevention programs, which Wyoming is fortunate. We have had 3 pilot programs. Cheyenne was the first through the Y, Sheridan through their Y, and Jackson through the hospital. But there are soon to be 9 more prevention programs throughout the state. And there are 70 of us in Wyoming that are going back to school. The first class was in August. The next class is in October. There will be 70 of us to begin to develop and put together prevention programs across the state. And that's been supported both by CDC and by the State Health Division, and a lot of support throughout even tribal and Indian health services to move Wyoming forward as a group. The American Diabetes Association has come to help us along with CDC and our health division to move us forward with their master trainers. So, in case you don't know, and it's firm, I know that we did a big conference in August, and somebody said, you know, when did prediabetes change and what did those numbers really mean? And when we said impaired fasting glucose is 100 or an A1C at 5.7 to 6.4, or that, you know, oral tolerance tests or the 20 jelly bean tests that we give to our kids, they're fast. And I think we have to not be afraid to think outside the box. We need to tell our patients that they're headed down the road to diabetes, and we need to offer them early intervention and not wait until they get to 126. I've had the privilege to be part of one of the trial programs, and our patients do well and they stay healthy. Or if they have problems, they're little problems, they can go have their hip or their knee or their cataract surgery or whatever they may need to have done with little or few issues. And people feel better. And some of our ladies who have never lost weight in their life are losing weight and feeling better, both physically and mentally. And therefore, we have healthier communities. So we have to think sooner than later. Because we've all seen the patient who's presented really, really ill, the young child or young adult who, you know, the parents tell you that they're eating well, but they're still losing weight, but they've lost, you know, 20, 30 pounds maybe sometimes because they've been so sick with their type 1. Our eye physicians will send us the patient who they think it's the blurred vision, and they don't know what's going on, and the docs can look in there and see the inflammation, the wounds that don't heal, the fatigue. You know, sometimes it's hard to pull these pieces out because a lot of our type 1 patients also come with thyroid and other kinds of issues. But if all of those look good, that 2 hour after you eat blood sugar, you know, send them to McDonald's, tell them to have a Big Mac and a fry and have a real Coke and come back and do a finger stick. And when it's 200, you don't have to do oral glucose tolerance. The men don't usually talk to me. Their wives will tell us that they're having sexual problems. But usually once the conversation comes up, neuropathy isn't just about feet and hands. Neuropathies can be all over the body. We see the ladies with the yeast infections, the vaginal infections, but we see more even with our gentlemen now. My favorite story is, you know, the person who thinks they have carpal tunnel, you send them for their EMG and it's normal, but when you talk to them, they have lots of other fibromyalgic kinds of symptoms. It's where that history is so incredibly important. And what can we do in a positive format in our screening to say, you know, their blood sugar is 99. Are they crossing that threshold? The A1C is our best friend because it is that look back at what's happening. What do those pre-prandial and post-prandial blood sugars really look at? And if you're exercising, everybody's thirsty, but our kids are really thirsty. You know, they're drinking a gallon of water and then they're urinating all day long. But even if you look at skin turgor, can you write your name on their skin because it's so dry even though they tell you they're drinking everything? Lots of little kinds of things that perhaps we haven't always looked at in the same light. The big picture makes you think, what else is going on? And since we're looking at 1 in 3 people, even in Wyoming, it's a lot. We talked about autoimmune disease. You know what? Our folks do great now. There are so many options for our folks with type 1 diabetes. The new pump, we did training, and actually we have, I'm actually in a place today where I'm doing more training this afternoon too. The new pumps that are out there, they're a tool. They're only as good as the folks that are using them, and yes, you still have to check your blood sugar with the new sensors, but the brand new pump will not only turn off if it gets low, because you can set that threshold, but it can give you, if you're willing to put it in auto, it will give you insulin to keep your blood sugars 120 to 180 all day long once we get it regulated. So there are some amazing new tools to go along with our folks for type 1 diabetes. And I have some folks with type 2 diabetes that are on huge doses of insulin that benefit from a pump because it gives those baby nudges of insulin all day long, so you don't get the destruction of the tissues from having to give 100 units at a shot. And with our new insulins that are U100, U200, and U300, we have more options of what we can do to help those highly resistant folks. And I challenge you that type 1 diabetes is not just about children anymore. And we're seeing more and more adults with latent onset type 1 diabetes, and they fit the mold. They get sick, they get sick, they get sick. They've had some calamity in their life. It could be a divorce, it could be an illness, it could be a death in the family, and it's the trigger for their cascade. My husband was 46. So, diabetes, that A1C greater than 6.5, the fasting greater than 126, the oral glucose tolerance. You do need 2, but it could also be a finger stick. So any combination of 2 or more to truly have the diagnosis. And again, for those of you that did the medication module a while back, and like I said, we probably need to do it again because there's some new changes. We have some amazing options to help our folks. Now, I can't get any 2 physicians to agree of when to have people test. And under the new guidelines, if you're only on oral agents, they're probably only going to give people 1 a day. If they're in control, we might let them test twice a week, but twice that day. If you're on insulin, they'll give you 3 strips a day. If you're on a pump, they can give you 4 or 5. If you're on a sensor, they're going to only give you 3. But if we can have folks be 80 to 130, 90% of the time, 2 hours after they eat, less than 180, and an A1C less than 7, we know that we're going to keep our folks out of trouble. But remember, just like blood pressure, blood sugars are age and risk appropriate. You know, we've got some 70 and 80 and 90-year-olds that live out on a ranch that it might be okay for their A1C to be 7.2 or 7.3 because you cannot put them at risk of a low blood sugar. Emergency help is too far away and they have limited resources. And I will absolutely be, we will all be waiting to see what the new guidelines, if they wrinkle these at all come November, because the big meeting is next week, and see what they've come up with. Here is a change, and this may change how some of us practice foot exams. You know, you look for that redness, the swelling, all of those things, but if they have any portion of microvascular disease, foot exam now should be done at every visit, not just once a year. It minimally should be done twice a year, because we all know that if you go over to that 366th day, we're no longer in compliance. So most people are doing a foot exam at least twice a year, so you're never out of compliance with the guidelines. But now the new guidelines clearly say that if you have any level of microvascular disease, it should be done every visit. So that may change how some of our folks, especially if they've had their diabetes for a while, especially if they have other kinds of things going on, how you change your visits for those folks. Vision exam. Most insurance companies will pay for the comprehensive diabetes eye exam, even if they won't pay for the glasses. And so Medicare, Medicaid will pay, as long as it's billed correctly as a comprehensive diabetes eye exam, they will pay for that. Getting that urine for microalbumin, even in our type 1 folks, if they've had their diabetes greater than 4 to 5 years, it should be done. And I love patients who say to us, I don't know why they put me on an ACE or an ARB. I don't have high blood pressure. And we have to take the time to explain to them it's about protecting the filters in their kidneys so that we don't do damage. It's not just about blood sugar. Flu shots, it is the season. The Pneumovax, the one before age 65, one after, new Prevnar, if folks haven't had the new version, conversation with providers about what does my patient really need, but making certain that we help protect our folks. Heart disease is still the number one reason for, number one complication causing death. Many people live through their heart attacks now because we have such great new procedures. But strokes are life-altering, and I think some of us are feeling a little more vulnerable when you are seeing people in their 50s and 60s again having early strokes. Diabetes is still the number one reason for blindness. And in Wyoming, I know that our Lions Club, if someone needs laser help or needs diabetes treatment, most of the Lions Club have money, and the Lions Foundation in Wyoming has money to help pay for patients' treatment. They'll even send them to Utah to the treatment, the Big Eye Center for specialty treatment. So don't be afraid to use your community resources. Again, nerve damage isn't just about feet and legs. It's what's happening in that gut. How is that food being digested? What's happening with your blood pressure? Is it responding? Is your heart responding to the load when you're out there shoveling the snow? So we have to think about those things. We don't see as many amputations as we used to. Amen, for good foot care and good wound options for treatment, but it's still an issue, and we all know that once you start surgerizing areas, frequently, you can start with a toe, and then it's a foot, and then it's a below the knee or an above the knee, and repeat surgeries are very much likely. And while it was the number one reason for dialysis for many years, it's running right neck and neck now with blood pressure. So the patient with diabetes and hypertension is more at risk for needing dialysis. And our renal partners will tell us that if their blood pressure isn't under control, their blood sugar won't be under good control. And if the blood sugar is not under good control, nor will your blood pressure be under good control. So it's becoming a duality of issues. And I think most of us think of our patients when especially for that newly diagnosed, is, are they 30 or are they 90? Because it is about quality of life. And where are there other risks? Do they have hypertension? Do they have some other T-cell defect, with their lupus or other kinds of issues? I know we see our type 1 folks, with many more thyroid and gluten intolerance lately, and many, many more complications that make taking care of their disease much more complicated. Have they already had their heart attack or their stroke, and now they're in the hospital and we pick up their new diabetes? And where are their resources? I can't write for a $200 or $300 medicine if they can't afford it. But there are great patient assistance programs now that do help. And most of the medicines that have been moved to Tier 2 are now covered by Medicaid and Medicare, even the Part Ds, because they're so much more effective for the money that we spend. And so it has changed how we practice. If I can give one medicine that's a little more expensive, but it does better quality of work, that's perhaps what we're doing more of. Takes a little more conversation. And many of our communities, I mean, we have 11, soon to be 13 diabetes centers across the state. Indian Health Services and Tribal Health are just applying now. Afton's one of the new sites this last year. Fremont County is working on their diabetes program, and I suspect by January we'll have their program up and running. We do have good resources. You do have some amazing community health centers across the state, you know, in Casper and Cody and Powell and Riverton and Rock Springs, for folks to enter the healthcare system a little more effectively. This is an overview that we do for the nursing students. This normally is a 2-hour class. So I'm going to open it up to questions or concerns if people have that. It's probably a better use of our last time.
Great. Thank you, Diane. This is Brenda. Go ahead, folks, and put your questions into the chat feature. I think that will work best. Remember, we will follow up the webinar with an evaluation. And if you're interested in obtaining, because this is available through this presentation, does qualify for that, be sure that at the Wyoming Primary Care Association that we have your name and address or email address and your discipline, so we can put all that together and give it to Diane for your certificates. Well, Diane, I also wanted to just share with everyone that you and I will work together to see how we can incorporate some of those medication updates with the trainings we already have scheduled.
Awesome.
That'd be great. Great. So any questions out there? I'm not seeing any come in. Diane, I did have a question, and maybe you covered it and I just didn't capture it in my brain when you went over it, but why do you, other than a life event, what is the reason you think we're having the latent onset diabetes that you're seeing it now?
I think part of it, you know, the body habitus is greater. You know, people have gained more weight over the years. They're eating differently. Our lifestyles are different. We're spending more time, as we are doing, in front of computers and things. I think that we have put an environmental burden on ourselves. So then if something else comes along, whether it's the illness, it's an injury, it's a life-altering event, we're seeing the cascade of events. And that's why I say that 18 to 24 months, sometimes people can go back about 36 months, and you put the picture of what's happening to them together, and then all it takes is one more thing. And I can say this because I have it in writing in about 10,000 places. My husband got that flu that everybody gets, and it was the final straw that gives the body the ding that turns off the body's ability to then compensate. Certainly we see whole families with diabetes. We see grandparents, parents, siblings. You know, those are the ones that it's a little easier to kind of figure out what's happening. That's why, TrialNet has been so important to look at the genetic components. And yes, there are families who have the genetic component, and they're looking at, what they can do to suppress those and get, especially the children through puberty where, the hormonal defects are already so great. But we're just seeing a cascade of lifestyle events. And I think then that one more thing comes along and it's the final straw. And I know it makes a struggle for practitioners because they go, oh, they're 45, they have type 2 diabetes. You put them on oral medications and they're still sick and they don't respond. That's why insulin has become quicker and use it. You know, their A1C is greater than 8.5. You put them on some insulin, you get them below 200. Maybe you start some oral medications, you know, for that patient that you don't know, because even a C-peptide has to be done paired with that fasting blood sugar when the blood sugar is less than about 175 to 180. Otherwise, it's inconsistently invalid. So if we get someone down, we get them safe, we do a C-peptide, and you go, oh, they're producing lots of insulin. They were just having this illness event. Okay, the oral medicines over time will work. You still may leave them on some insulin for a while the oral medications become effective, because a lot of our oral medications, you know, take 2 to 6 weeks to really come to steady state. But you don't want that patient to stay with their 300 and 400 blood sugars. And so I think we've had to change the paradigm of how we practice. Insulin, for many people, is less expensive than all the other big oral medications, and so it may make a difference. But for our, you know, it's pretty easy sometimes when our children present, unless those of us who are a little fluffier look at our kids and go, grandma's got type 2 and mom's got type 2. They're a girl who's going through puberty and she gets sick. You know, it's going to be those things that make you go, You still may put them on insulin to start, but those are the folks that we're going to do the C-peptide and perhaps at a pro-insulin level, you know, with that fasting blood sugar, because we need to know. We need to know what they need to have for the rest of their life. And especially our 30 and 40 and 50-year-old adults, you know, if we know that eventually an oral medication, you know, is going to be helpful, that's fine. Do we send them to the dietitian? Absolutely. Do they need to be eating healthfully and exercising? You bet. But if we can get them feeling well mentally, because, you know, your body and your brain's pretty boggy when your blood sugars are up, we can begin a process. And diabetes is a journey. It doesn't matter whether it's type 1 or type 2. It is a lifelong journey. And it takes partners. You know, I have my dietitian partners that I've worked with, you know, for years and years and years and years. And I've had the privilege, you know, to work in the same diabetes team for 22 years. They're my best friends. I can write a basic diet, but I want my dietitians to do that, you know, to help me out. But it's about lifestyle, and it is about finding the balance for each person. It takes work, and anybody who says it doesn't, and I guess I'm a little more sensitive, and I'll just be right up front. When you have a husband with type 1 diabetes, you just know that it takes work. But even our families, diabetes isn't just about the patient, it's about the whole family, because a lot of families have to change their whole life to help be healthier. And I think that's why the new prevention programs will become, today they're nice. I think now they are having us really take a good look at what we've done to ourselves. And I know the new diabetes prevention programs are year-long programs, you know, that the end outcome is, you know, 5 to 7 pound weight loss. But we know that even a 5 to 7 pound weight loss and changing how you eat changes your whole chemistry in your body. And the success rate is amazing. So, you know, some of us who've been part of it, some of us who have watched and have been part of the medical component of it are seeing the benefits, the long-term benefits for patients. I've got patients that we've been treating for their prediabetes for 5 to 7 years. And guess what? They feel wonderful, and they're healthy, and their minds are better, and they're a more productive person. And they have quality of life without complications, or with very minimal complications. That's where it is.
Right, right. Thank you, Diane. So we've gotten actually quite a bit of activity in our chat box while you were, that's okay. It's all good information. So thank you everyone for putting their contact information. We're capturing that. We'll make sure that gets to Diane for your certificates. And then Diane, I don't know if you can see the question that came in the chat box. It says, thank you for this great information. Can you direct me to the STEPS program that you mentioned earlier? I think that's what it was called. Also, I think you said there would be a program later on diet management. If not, go ahead.
Yeah, there will be. I think, isn't that the November 1st?
Yeah. So we're doing that one, and that so if you received information from the Wyoming Primary Care Association about this webinar, you're on our listserv. Somehow that got to you, which we're thankful for, and you'll get the next one. And when we started, I gave the dates and the topics, and actually just as a, you guys already have the link to get in, but we'd like you to register for each one so we can know who's coming and how many to expect. But yes, we're doing that. And then I'm not sure what the STEPS program was that she referred to.
I'm typing it in a second. Only if I can spell. If you go to diabeteseducator.org, it's the American Association of Diabetes Educator website. Across the banner bar, under education, it says become a CDE, but under become a certified diabetes educator, there's an education program there's a STEPS 1 program, which is for like community health workers or perhaps CNAs. It's done at that level, probably 8th or 9th grade level. That is basic knowledge. You actually get CMEs for it. It's a very cost-efficient program. It's less than $200. Takes you anywhere from it can take up to 6 months for some people to do. I think there's 9 modules, but it's the basic core of anatomy and physiology and a good review of diabetes, so that you have support people who really need to help you, they can. And then there's a level 2 program, which is what a lot of our nurses and LPNs and RNs and ancillary professional staff will do. And that's the one that will actually give you a certification as a level 2 certified educator. That is what a lot of our small practices are using to build a champion in your office. And a lot of our folks, after they do that, will contact us, and we will help folks sign into Cornerstones for Care, which will allow you to get all the free books and handouts, everything from a sick day handout to a low blood sugar handout and everything in between that is free. And it was they're all NCQA, so they're all National Quality Assurance certified tools that are free to us here in Wyoming to use as a continuity and consistent resource. There's some on meds, some on diabetes. There's a great, amazing food book that talks about carbs and options and those kinds of things that are available as a toolkit for those sites. And we've helped a number of sites have great resources so that they can do that. And in that program, it takes about 6 months to do, depending on the person. It takes about 6 months, and you actually get continuing education credits for doing that. But for some of our sites that will never have, a certified diabetes educator, or don't have access to a certified diabetes educator because it's a long distance kind of thing, they can actually give good information and good resources. But our Mountain Pacific Quality Healthcare partners also have the DEEP program, the Diabetes Empowerment and Enrichment Program. That's a community-based program that's led by community champions that help support and partner with that too. So you can actually do classes for folks with diabetes.
Wow. Hey, thanks, Diane. I think we better go ahead and cut it off. Thank you, everyone, for joining. I want to thank Kathy back at the office for being our technical wizard today and making sure everything ran well. Diane, thank you so very, very much for this information, and we look forward to having you speak to us again 1st of November.